Right. It's a minute past, and I can see already about 60, 70 of you have logged in. We've got about 300 people registered, so they will be on different platforms as well as this platform. So, good evening. There's a distinct hint of spring in the air. It's warm, and I actually saw some sun today. Now, that has to count towards the renewed energy for a cause that you and I so passionately believe in, primary care. Our journey on this learning platform over the last 2 years and a bit has allowed us to share some good practice examples and steal with pride those fabulous things that others have been doing to improve care for our own patients. Welcome again to the Future of Primary Care webinar series. I'm your host, Mohit Venkataram, and I'm a doctor by background and an executive director at East London Foundation Trust. The popularity of our webinars has been enormous. Over 300 of you are registered today for this webinar. And fascinatingly, even NHS England has renamed its transformation program after this webinar series. It would not have been possible without the absolutely magnificent participation we've had from so many of you from different quarters. Our foray into primary care was with the explicit understanding that primary care colleagues got the smallest proportion of the NHS budget and yet saw some of the largest number of patients. And interestingly, they were able to keep many people safe in the community, caring for them, ensuring their long-term conditions were managed, and ensuring primary prevention was done well. Now, that makes them a true cornerstone of a safe future NHS. These webinar series are one of the investments we make as an organization so that together we could share corporate resources in a way that allowed us to deliver safe, effective care for our residents. Now, every month, I've been sharing with you some fabulous data about the performance of primary care. Every month, I have shared that almost 30 million appointments are delivered on a monthly basis in primary care. Do you know, in January, a new high was achieved. 32.5 million appointments were delivered by primary care. Isn't that a phenomenal number? Of these, 93% of appointments were attended. Almost half of these appointments were same-day appointments. About 2/3 of these appointments, 66.7%, were face-to-face appointments. Now, how many parts of the health sector can stand with pride and talk about such phenomenal access data? To the amazing heroes who work in primary care, well done. But for you, many of the rest of us would have struggled to deliver safe, effective care in secondary and tertiary services. Interestingly, this month, NIHR has also advertised for some research opportunities in primary care. So get your skates on, folks. For those of you who have an interest in research and would like to have some practice fellowships, please put in your applications now before the deadline on the NIHR website. How often in primary care have we spoken about the challenge of working with secondary care? How often have we said things could be better if we could work along with the secondary care colleagues? Well, one such consultant and one such trust has started changing this completely for the future and for our patients. Consequently, the local residents there are getting much more support than many other parts of the country. While many of us in primary care still talk about trying to implement advice and guidance fully, amazing leaders like Dr. Lucy Abbott and her trust have already been implementing services firmly entrenched in the community and primary care space. Dr. Abbott is the chair of Frimley Health ICS Aging Well Board and also a consultant geriatrician and chief of service for community and older adult medicine, known in many of the publications that have been talking about her and the remarkable success she has achieved. Her investment in the area of community and primary care is leading to a different relationship between GP colleagues and secondary care. We are extremely pleased to have Dr. Abbott with us on this webinar today, sharing with us her journey, her learning, and her experiences, but most importantly, creating a new NHS that is free from boundaries, especially organizational boundaries. But just before I hand over to Lucy, I'd like to remind colleagues that you are welcome to post your questions on the Q&A section of the Zoom. For those of you on different platforms, I'm afraid that facility is not there. I'm aware many colleagues have already posted their questions when they registered. Those will be picked up, so please be assured they will not be missed. And now, without further ado, let me hand over to the amazing Lucy. Thank you so much for joining us today on the webinar, Lucy, and thank you for giving us your time. Can I hand over to you to share your journey?
Absolutely. Well, thank you very much for that very kind introduction. So, as Dr. Mohit has said, I'm a consultant geriatrician, initially employed to work in an acute trust. But as we all know, actually people spend most of their time at home rather than in hospital. And very much as when I started my consultant journey, I was really keen that we kind of shifted the focus out of the acute hospital and made sure that we were supporting older people to age well in our local area. Are we able to share the slides? Lovely. The next 20 minutes or so is essentially just really give you an idea. If we can just move to the next slide.
Just hang on for a moment. I think Dr. Abbott's frozen. Lucy? Sarah, can you just check Dr. Abbott's status? Sarah?
Hello there. Apologies. Just checking with Dr. Lucy.
Thank you.
Give me an
Oh,
update.
sorry for the technical glitch. but if there wasn't a technical glitch, we'd never feel comfortable with IT. So give us a moment and we'll sort it out for you. Yep, I can see her back.
Oh, gosh, I have absolutely no idea what happened there. I'm so sorry.
Oh, well, you're back. That's what matters.
I'm back. Good. Okay. So, yeah, so what I'm hoping to talk about in the next 20 minutes or so is talk about what we mean by frailty, how we are trying in the Frimley system to get it right for people living with frailty, and focusing on actually what's important to that person. And thinking about how we try and help proactively, and also what we do from a reactive perspective when someone does fall into crisis, and then also share a case study with you if I've got time. So next slide. So I thought it would be sensible for us just to have an overview of what I mean by frailty, so that we know what we're talking about. So frailty is more common as we age, but older people cannot have frailty and be very physically robust, and younger people can have frailty. And I've put the definition of what frailty is there. So it's a long-term condition. So we need to think about frailty in the same way that we think about diabetes, COPD, heart failure, etc. And it's characterized by essentially a loss of reserve across all of your organ systems, which means that you're very vulnerable to decompensating after a stressor event comes along. And for someone living with frailty who's very vulnerable, that stressor might be quite minor. So, for example, a urinary tract infection classically, or a breakdown in their social circumstances. The little diagram on the right of the slide kind of is a pictorial representation of what happens to someone with frailty and how they end up in frailty crisis. So someone with frailty will have a certain amount of functional ability, so they're above the line of dependency. Then because they're vulnerable, the minor insult comes along, and that causes what we call a decompensation in their function. So that's when they might fall over, become delirious, have reduced mobility. And that's when they present with a frailty crisis and come to our attention, particularly often through 999 or in A&E. Our job as a multidisciplinary team is to obviously identify what's caused that decompensation, treat anything reversible, and then obviously offer rehabilitation to try and get that person with frailty back to a certain level of independence. Frailty is a spectrum, and we sort of advocate using the clinical frailty scale, which is on that slide. And it's a very easy pictorial scale, and it enables you to kind of identify where someone might be on that frailty journey. And generally, we're sort of as geriatricians, and in terms of the people that we're wanting to work on, it's the CFS score of 5, the mildly frail. That's where we are trying to think about preventing frailty progression, and then 6, which is moderately frail, and 7, severely frail. If we move on to the next slide. So if anyone wants to know sort of more about services for older people, etc., then the British Geriatric Society is the website's got loads of resources on there. But fairly a few years ago, they released this position statement about sort of primary care for older people. And that looked essentially and advised about what we needed to do for people who are on their frailty journey. So, as I mentioned before, people living with mild frailty, basically exercise and good nutrition, protein, micronutrients, we have been shown, evidence-based, is that you can actually sort of reverse mild frailty back to being pre-frail. So really, it is that kind of trying to prevent frailty progression stage. Then in the moderate frailty category, this is when we're looking at sort of managing long-term conditions. We might be thinking about offering a comprehensive geriatric assessment. So that's a kind of multi-professional, holistic assessment of someone's medical conditions, medications, their social situation, their psychological state, their cognition, their social situation, etc. And then when we move into the severe frailty category, so that's your CFS score of 7, for example, people who might be living in a nursing home, might be bedbound, supported by carers, etc. That's when we need to focus on the fact that someone might be reaching end of life, and we need to think much more about advanced care planning. And if that person does end up in crisis, looking at providing a kind of community-based response to that person who's become unwell, because we know, again, evidence tells us that when you get to that stage of frailty, that chances of having a meaningful outcome from an intensive care admission or a high dependency unit admission is small. So we know that those higher levels of care aren't necessarily appropriate for that population. Next slide. And as I mentioned before, older people with frailty generally want to be at home, supported by their family, supported by their carers in their usual environment. And although we strive to make hospital care as safe as it possibly can be, unfortunately, hospital-related harm for people living with frailty is significant. So we all know that when people come into hospital, there's a risk of deconditioning, so physical deconditioning, but also psychological, social, because they're away from their normal support network, and people often become more confused and disorientated in hospital as well. Obviously, people can acquire infections in hospital, sometimes are unnecessarily catheterized, and that can be associated with infections as well. Increased risks of pressure ulcers because of immobility, and medication errors as well. And just on the right there is a little graph of some patient experience work that I did in the trust, and you can actually see how anxious people are, particularly about being on the first column there, being admitted to hospital, that they get very anxious and unhappy about coming into hospital because that's not necessarily where they want to be. Next slide. So what we are striving for essentially is to deliver the right care in the right place at the right time. And NHS England have had their Ageing Well strategy, which has encompassed those things in the 3 boxes. So a proactive care approach, a specific programme of work for people living in care homes, the Enhanced Health and Care Homes programme, and then also rolling out urgent community response and frailty virtual ward, sometimes called hospital at home services. And we're lucky enough within our Frimley system to have all of those things. And really, this is just a diagram to show that patients will move, people will move throughout all of these settings, and all of those settings might be the right place at the right time for that person. But it's important that someone doesn't end up in the wrong place at the wrong time. So ideally, we obviously want to support people as close to home as possible. We have multidisciplinary integrated care teams, obviously, primary care, GPs, our community services, specialist nursing, social care colleagues, voluntary care colleagues, mental health, hospice, ambulance services, etc. So all of these services are there wrapped around people at home, and we obviously need to make sure that that's a coordinated approach. Unfortunately, we do know that people do fall into frailty crisis, and in that sort of situation, that's when we're hoping that our kind of urgent community response and frailty virtual ward team will go out to that person and provide care at home or in their care home if possible. Sometimes people need a level of care that can't be supported at home if they've got 24-hour care needs. In that situation, we'll often be bringing them into our community rehabilitation wards, so into one of our community hospitals. And sometimes people do obviously need to come to the acute hospital, in which case that ideally they're seen by our kind of front door frailty same day emergency care team, and that person's returned home with the appropriate support if possible, or if necessary will be admitted to one of our inpatient beds. And obviously we aim to try and minimise that length of stay as much as we can. I've put a little quote there on the slides from one of my GP colleagues, who said that the cross-organisational frailty system is the best thing that's happened to the primary secondary care interface for years. So when we get it right for people, it really does work, and that's the important thing. Next slide. So we also have a remote monitoring program within our system, and again, we very much think of it as a continuum of care. And so the level 1 patients, that's much more about self-care. So for example, that's patients measuring their own blood pressure. Then we've got patients that maybe have sort of chronic long-term conditions such as heart failure, COPD, etc. And they'll be measuring their ROBs, weekly, a couple of times a week, sort of example, measuring their weight, their saturations, etc. And they know their numbers, and then they know when there's any deviation and when they need to ask for help. For example, a patient with heart failure who might be gaining fluid and gaining weight. Then we've got specific cohorts that we monitor, so care home patients, patients that are deemed to be high risk on our population health management tool. Then if they become more unwell and end up on the virtual ward caseload, then we might be using the remote monitoring so that people can take their observations maybe 3 times a day or 4 times a day in a similar way that they would do in hospital, so that we can monitor for any acute deterioration. And then obviously, finally, if someone becomes significantly unwell that they do need acute admission, then they obviously come off the remote monitoring program and come into the hospital. Next slide. So obviously, ideally, we want to be as proactive as possible. So we started our kind of proactive care journey in the Frimley system back in 2017. Next slide. And this is a bit of a busy slide, but essentially it gives you all the detail behind really how the proactive care system works. So we start off using our population health management tool to identify cohorts of people that we can proactively work with. So we have 2 cohorts that we're predominantly working with at the moment. That's a cohort of patients with moderate frailty with 10 or more long-term conditions. And then there's another cohort of patients with moderate and severe frailty who have actually had no contact with their GP in the last 6 months. And the worrying thing about that, we feel, is that perhaps they might be people that are flying under the radar and then will end up in a big crisis that we could have potentially avoided. And then we have 5 places within our Frimley system, and we also support places to actually define their own cohorts that they think would be important for them. So for example, you might be looking at areas of social deprivation, for example, and sort of focusing on your own health inequalities maybe. That generates a list of people. There then needs to be a clinical validation to make sure that the people on that list are the people that should be coming to the MDT. And then we have sort of frailty practitioners who are often from a therapy nursing background, will go out and meet the patient, the person, and they essentially undertake a sort of mini comprehensive geriatric assessment of that patient in their own home. And the key thing is that they really find out what matters to that person, because there's no point making all sorts of suggestions about interventions, etc., if it's not actually going to make a difference to that person. Then the patient doesn't physically come to a multidisciplinary team, but we have a virtual MDT, social care, mental health, geriatrician, GP, community nursing, community therapy, everyone there. And we very quickly just discuss the case, make sure that everything's been addressed, polypharmacy's been reviewed, falls risks been reviewed, bone health, etc., advanced care planning where it's appropriate, and then we come up with a plan that then gets taken back and discussed with that patient. And the important thing is we record it on our system, and then again that can be seen through the shared care record. So that's a sort of a rough overview of what we do. Next slide. Now, as you can imagine, actually showing any sort of metrics and data around the impact of proactive care is really challenging. So this is quite old data. This is some of the data that we measured right at the very beginning. But the interesting things is that the top 3 interventions that we were recommending were crisis planning, medication reviews, polypharmacy reviews, and falls and mobility assessments and falls prevention, which of course we all know are cost-effective interventions for older people. We showed that we made significant savings on polypharmacy reviews, and when we followed up the people that we'd worked with for 3 months, we had about a 30% reduction in A&E attendances and admissions between before and after that person had been discussed at the Frailty MDT, which of course is good for patients that they're not having to come to A&E, and also saves money for the health system as well. Next slide. As you can imagine, we get really positive feedback from the patients. So here's just a few comments, but certainly they really value having that input, and also the feedback that we've had from staff as well. Because obviously one of the challenges that you get are staff saying, "Oh gosh, this is extra work," but actually once they start doing it, they then realise that they're sort of preventing the crisis, and it's actually better to invest in putting the proactive interventions in. Next slide. So that's the kind of proactive work we've been doing. Obviously, as I mentioned before, people with frailty do end up in frailty crisis. So then we've obviously tried to respond to that by providing a home-based responsive service. Next slide. So in April 2021, we set up our Frailty Virtual Ward Hospital at Home service. And as I mentioned before, often when people are living with frailty, it's not the right thing to offer non-invasive ventilation, inotropes, etc. So the kind of care that we would offer on the acute hospital ward, so oxygen, nebulizers, intravenous antibiotics, intravenous diuretics, we can give in the person's home. And essentially that's what we do. So it's acute hospital level care that we provide in the patient's home. Again, it's a multi-professional team of therapists, advanced nurse practitioners, geriatricians, and essentially we try and replicate the acute care in the person's home. Next slide. So again, here's just sort of our dashboard of the patients that we've seen. As you can see, as we built the service up, referrals are just going up and up and up. We keep 96% of our patients out of hospital, which is, I think, pretty impressive. And the other thing is that just sort of looking at where our referrals are coming from, we're getting several referrals from GP 999, 111, etc. So we really are getting in, seeing patients straight away, and they're not needing to come to the hospital. Next slide. And again, just a bit more feedback on the service. So patient surveys, the patients absolutely love it. They love being treated at home. 100% of patients would recommend the service and would prefer that model of care to being admitted to hospital. And also we've had, our local GPs and our local community nurses, etc., also really value the service, because when they're seeing patients, they often know it's not the right thing for them to come into hospital, but they do want them to be actively treated. And the other thing is that often for our patients with frailty, sometimes they don't respond to the acute treatment. But if that's the case, then they're generally in the place where they want to have their end of life care. And it means that we can then switch the approach to end of life care when it is appropriate, and they're not having that happen to them in hospital and dying somewhere where they don't want to be. As we know from our data, we are preventing hospital admissions, and again, you can see that we think we've, for this cohort of patients, we've reduced A&E attendances and inpatient admissions, and this is after we have seen them. So essentially what we were doing was following these patients up, and this meant that, so they're not being admitted whilst they're on our caseload, but they're also not being admitted in the subsequent 6 months. And I think the main reason for that is because we do a lot of advanced care planning and complete something called the respect form, which is the local form that we use, and that sort of explains people's future wishes for future care. Next slide. So just a little bit of learning from us really, is that when we started the proactive care model, when we started the virtual ward model, we've started really small, and then kind of built confidence in the service and refined our processes as we've gone on. In terms of when we sort of started some of this work, people thought, well, how does that differ from what we're doing already? And really, it's important that we didn't disrupt any of the business as usual processes that were working really well. And actually, we just wanted to complement and augment what could be done in the primary care setting. And obviously, communication with GPs, out of hours services, the acute hospital is really communication is the absolute key to this. Really important to collect the data as we went along, because then we were able to demonstrate the impact, and then obviously that helped with future business cases, etc. We were really clear about the governance of the service right from the beginning, and again, because obviously people were quite concerned about us giving this acute level of care in people's homes, but we're clear that when they're on the hospital at home caseload, they're under the geriatrician, etc. And unfortunately, you do need to have a senior team. So advanced nurse practitioners, geriatricians, etc. You do have to invest in it, but that senior clinical decision making is absolutely key to ensuring that patients don't need to come to hospital, making the escalation plans, as I say, completing the respect forms, and having those shared decision making conversations with patients and carers, which is so important. And then, of course, you've got to make. I've got a picture on there of the slide of some of the kit that we carry around with us. But we've got point of care testing. We have the remote monitoring. We've got access to sort of frames, commodes, etc. And we also have some access to short-term care, or we work alongside social services and existing care agencies, because often when people with frailty are unwell, they do have increased care needs as well. Next slide. So just very quickly, just a case study to kind of illustrate what we're striving for. So traditionally, you might have an older person on medications, suffering from postural hypotension, socially isolated. No one's asked her what matters to her. She falls over, calls 999. She's not injured, so they pick her up. And refer her onto the falls clinic. But unfortunately, while she's waiting for the falls clinic, she falls again, fractures a hip, ends up in hospital, becomes delirious, ends up needing rehab, going to a community hospital, and eventually goes to a nursing home. Becomes unwell in the nursing home. There's no advanced care plan. Saturday night, 999's called. There's no other option but for the patient to come back to hospital. And then, unfortunately, despite treatment with fluids and antibiotics, she becomes more unwell and then receives palliative care in the hospital. So I think, unfortunately, that's a story that probably many of us would recognise. What we're trying to shift the care towards, if we move on to the next slide, is that you can see how for this lady, that actually she could have been picked up in the proactive care cohort. So she would have been one of those ladies that's not seen her GP for 6 months. But if you do the lying and standing blood pressure, you do the polypharmacy review, you fix the postural hypertension, she won't, less likely to fall over, identify as needing osteoporosis treatment, then you prevent the fracture. Early referral to memory clinic to help prevent cognitive decline, having that conversation with her about what matters to her, completing the respect form so that she can have her care at home, maybe making some adaptations to the house, again, to minimize falls risk, getting social prescribing involved to minimize social isolation, and then thinking about those proactive things, nutrition, strength and balance, to prevent falls from happening. And then you don't have that first fall. Next slide. Unfortunately, we do know that obviously people do age and that, things happen. So eventually she does, after another year, she does fall. But she doesn't fracture this time because she's been on her bisphosphonate. And because her respect form says that she wants to have treatment at home, that 999 just directs the referral through to the urgent community response team that come out. Again, therapy, equipment, medical review, polypharmacy review, etc. Again, frailty progresses over another year, and she does eventually end up moving into a care home. Next slide. But because of the care home programme, she's having regular review by her GP. She's got her advanced care plan. Again, she becomes unwell on a Saturday evening. But again, this time, because she's got a respect form saying she wants to have care in the care home, again, the urgent community response and hospital at home service come out, try and give her treatment in her care home. Again, unfortunately, she's so frail, it doesn't work. But then actually we can shift to a palliative approach, and that's where she's died actually where she wants to be. So that you can see how the story can be different by just having a slightly different model of care. Next slide. So that's everything I've got to say. This is the team giving hospital at home care out in someone's garden this summer. It's not always as pleasant, but yeah, this was a lady who was dehydrated, but her family had managed to get her out into the garden, which is where she wanted to be, and she's having her fluids and her antibiotics there. And that's it from me.
Lucy, this is so, it's so heartfelt. The whole process, you feel it is just amazing. And the very fact, can I have Lucy on the screen too, not just me? I look scary enough. On two of me is a worry. Thank you, team. So I think this was just amazing because as I'm getting close to my age when frailty is about to hit, you want to have services that allow you to live in the community you're comfortable with, the social connections that matter to you. So many fabulous things from just living at home, because the psychological impact of this on the patient, on the citizen, on the resident is so much more. And then their buy-in into the fact that there is hope is more than just being admitted in a hospital. I mean, what a phenomenal story, what you've shared with Doris. The change, of course, all of us know that at some point we all are going to die, but being able to do that respectfully, surrounded by people who love you, in an environment where you feel you have control, you can still be in contact with things that you love. Wow, what a fabulous way for a glorious life to be celebrated. Hats off to you and the team. Well done. So, as you can imagine, there are tons and tons of questions flying around, but I have the pleasure and the joy of picking up the ones that matter to me very quickly. This, without a doubt, is an initiative that will help in so many parts of the country. It'll have to be modified for the demographic needs, for the socioeconomic conditions there. But in a world where money has become so tight that no one wants to invest and everyone just wants to disinvest, what would be your advice of how they should approach this? Because I can see how many GPs, how many clinicians, how many nurses and advanced therapists will be sitting right now and thinking, golly, if we did this, it'll cost half the money and give better care. But there has to be an upfront cost of starting the team before you can start counting the saving. How did it work in Frimley? What made it work?
Yeah. So I think first of all, so there has to be a bit of a leap of faith. You've got to be brave and just sort of all decide that it's, get the right people together and decide that it's the right thing to do. And really, in terms of the proactive care, a lot of that is just coordinating what you already have. So, we have pharmacists out there doing polypharmacy reviews. We've got therapists out there doing falls reviews. You've got your GPs doing long-term condition reviews. So actually, a lot of it is just coordinating what you have already got. And again, as you say, that will be very specific to your local, your local area and your local services. So yes, you might need some kind of care coordinator or something that brings those people together in that kind of virtual MDT meeting. But in terms of investment, there are people out there doing a lot of this stuff already. It's not necessarily done in a kind of coordinated patient-centered way, where it's kind of, focused around the patient. In terms of the reactive stuff, there's quite a compelling financial argument for that, because older people, when they end up in hospital, occupy a lot of hospital bed days. And actually, it's quite easy to show that that's financially, the return on investment is good for those services. But again, you do have to persuade someone to invest in it in the first place. But the argument around freeing up hospital capacity to improve A&E flow and A&E performance, particularly at the moment, is very strong. And of course, we know is the right thing for patients.
I think the bit what you said, which I really, really loved, was get the people around the table to have a conversation, get the right people who really want to do it. And it's fascinating to see how much we are already doing, but we are doing it in an uncoordinated fashion. So the impact is not felt. We don't know what each of us is doing and making the difference. And I mean, at the end of the day, we are using public resources. It is our duty to find the best way of using it so that it's most efficient and provides good care to our residents. So I think it's really good to hear. So folks, those of you who have posted the question on how do you get funding, there is no magic bullet, firstly. But get people who are like-minded together on a table to have the good conversation. But be upfront to have a conversation around what we are already doing and doesn't need additional resources, but needs a change in the way it's approached as a single coordinated team. Because it's really interesting, the richness of data that is available on EMIS and System 1, but it's quite often not accessed by the secondary care clinicians, and you don't give access to it. It's impossible to have a single MDT to sit and discuss which patients are more likely to be there. And I think, Lucy, one of the things that has been posted, rightfully so, is the proactive care element is probably incredibly crucial because 75, 85, 95, we will all be reaching those ages soon. But one of the key things that does very quickly decompensate someone in an older age is things like UTI, like upper respiratory tract infections, things that are very quick and common to get, but if not cared for early enough, tend to start creating problems that become niggly and then result in that level 7 we were talking about. So one of the questions that's posted about is, what should people do in terms of advising elderly relatives to care so that the prevention is as strong even before the initial phase sets in?
Yeah, absolutely. So I think a lot of it is about asking the questions that sometimes we don't like to ask. So for example, if you're thinking about trying to prevent UTIs, asking about people's continence, and whether they're having any low urinary tract symptoms, vulvovaginal atrophy is very common in, older women, etc. And, these are all things that we can actually treat or try and improve symptoms if we know about them, but it's not the type of thing that people talk about. And I mean, generally, things that are important, so strength and balance training is really, really critical. So again, if you go on the Age UK website and the Chartered Institute of Physiotherapists, you'll find strength and balance exercises. Again, they are shown to prevent frailty progression and improve and reduce falls risk. And as I mentioned before, nutrition, and then of course not smoking, reducing alcohol intake. Social interaction is really, really important. Social isolation is worse for your health than smoking, massively contributes to dementia, etc. So staying socially active, staying socially connected is really critical. And then, all the other things, having your regular blood pressure checks, making sure you're on the right medications, having your vaccinations, your flu vaccine, etc. They're all critical things. And then, of course, thinking about all the non-medical things, so wills, how you're going to get around transport, planning ahead with that kind of thing, is also really important.
It's just amazing to hear when you talk about the whole holistic care of the individual rather than getting stuck in the medical care, because quite often the medical care is less than 3% of what they want. It's the rest of it that makes all the difference and gives them that psychological sense of comfort that someone recognizes their needs.
Yeah.
Colleagues have been putting in a lot of comments. I mean, there's some interesting comments about, will this replace GPs with nursing practitioners? Colleagues, if I can just come in and say, there is nothing that's going to replace any professional group. There aren't enough people to do the job. So if we can all focus and do the job together, we would actually be able to use the same resources. GPs are a vital part of this resource. There is nothing that can replace them. The fact that we
Yeah.
have the professionals helps us use the GPs then at the right place rather than them having to do everything else too. It's the same for consultant geriatricians, because if you could give one consultant geriatrician per older person, it'll be brilliant, but you can't. So the suggestion is you get a multidisciplinary team and the right professional with the right skill interacts at the right time with the right individual in the right place. And that's the principle that's being attempted here, which
Yeah.
Dr. Abbott has successfully cracked in.
And it does take time. So one of our proactive frailty practitioners is an OT by background, and when he started, needed a lot of support and advice, but now he goes out, he asks all the right questions, he can do a lying and standing blood pressure, and he's coming to me and he says, oh, Dr. Abbott, this patient's on amitriptyline and I'm worried about their anticholinergic burden, and it's, so I'm like, yeah, absolutely, but that's taken 3-4 years, but as you say, it's the right person with the right skills, the right team, all coming together.
And a couple of really interesting questions about recognizing frailty is still captured within a certain age group, but life is different for different people. And it's interesting how many people who are still working may well decompensate quickly, may or may not be in the older age category as we historically used to call it, but still can require support very similar to the frailty pathway you put in. Do you have any advice, Lizzie, on a couple of things? The first one being, how should people who are younger, but maybe on the fringes of pretty similar things, access such services? And two, how do you support people in the psychosocial environment where those friendships that help you don't actually always form because you're working and you're of a younger age group, because most of the centers either cater for the older age group or the very young age group, and the working age, which has extended over time into their 70s and sometimes late 70s, are feeling left out. So any thoughts on what should be thought about?
So if I pick up the first question, which I guess is about access. So all of our frailty MDTs are actually open to, so we do the population health management proactive stuff, but if anyone is worried about a patient that they've encountered, they can come to the MDT, if you see what I mean. But obviously that person does need to be known to social care or a health professional or someone who will bring them to the MDT. I think if you get it right for people living with frailty, you will get it right for pretty much everybody if you've got those structures in place. And in actual fact, in one of the places where I work, the frailty MDT, we've started doing a learning disability MDT just beforehand. And essentially it's the same set of professionals that are there. So I'm there. I'm not an expert in LD by any stretch of the imagination, but we have the LD team from social services and the LD team from the mental health team, and they will bring sort of complex, obviously often much younger individuals, but a lot of the skills that we have in the MDT around capacity, best interests, polypharmacy, etc., are very relevant. So I think you can, as I say, if you get it right for people with frailty, you can expand it out to, younger people with complexity and comorbidity and what have you.
Fabulous. So folks, fabulous to hear what started out as a conversation about frailty and old age actually has very quickly evolved into the right care for the right person with a group of clinicians who want to do the right thing. So it's a lot about getting the right people around the table to find the right answers for the local population. And I think what I really loved, Lucy, was when you started out by saying there's really no point doing about something for someone without asking them what they want as an outcome. Because it is
Yep.
about them at the end of the day. And I think I absolutely loved that sentence when you said, and I thought, how relevant to recognize the power of the person, because their persuasion to want to stick with the plan with you as a colleague, as a co-producer, is only going to matter if they themselves believe in the plan and they actually own it. The question that has been posted is phenomenally powerful. How do carers feed into this plan development? Because many carers are actively taking care of people with frail conditions at home with very often no input from clinicians.
Yeah. And of course, you've got formal carers and informal carers. In the same way that you ask the patient what matters to them, it's really important to involve the carers in those discussions. So, and that is the beauty of looking after people in their own home, in their own environment, is that you often encounter the carer while you're there, and so you can involve them in that discussion. And also, as part of our holistic assessments, we very much consider the carers, and if we feel if there's carer burnout, if the carer themselves needs a support assessment, etc., then we can provide support for the carer as well as the patient. So yeah, it's really critical that the carers are involved in any kind of plan or discussion, because they're there providing, we drop in and out, but they're there providing the care all the time.
Phenomenal. And I think one of the things that was interesting was when you started speaking about care homes. And of course, it was towards one of the latter end of your slides, stages of frailty. How did you engage? Because there are a few questions around, do you have to share your wishes with the care home? How sometimes care homes don't listen. How do they engage? But the real question when one pulls out the crux of what's being posted here is, how do you get the hearts and minds of many of the care homeowners who are in a different place, both financially and contractually, so that together they are part of this thinking to get it right?
Yes. So that has been, again, this is not a quick thing. This is something that you have to work on over a period of time. So what we have discovered is that once you look after a patient in a nursing home, they then understand what it's all about. They see the benefit of it, and then they will use the service again and again. But often having that first patient is the first obstacle. Certainly where we, in our local area, a lot of the care homes are owned by sort of Bupa or the big care companies, and actually in those situations we've often had conversations with their sort of like quality lead to sort of, because obviously there's concern about we leave cannulas in patients if it's safe to do so we don't have to cannulate them every day and all of that kind of thing, and the remote monitoring, of course, etc. So it's about building the relationships, and when we first started the service, we were going around all of the different care homes with leaflets and all the rest, and even now we have care homes that we very rarely go into, but we know that we could do more there, and obviously so the advantage of working on it on a system basis, periodically I can have a look at the ambulance conveyance data and see which nursing homes are conveying more patients to A&E. And then we know I can have a look at those patients, and then I can, then we can go back to them and say, well, actually, what's going on? And it's interesting because one one nursing home flagged, and then we went out to have a conversation with them, and it turned out that they had lots of young patients with MS, patients with trachees, younger patients, and actually a lot of the patients coming in, it was completely appropriate, and it's the sort of types of patients that they were looking at after, and once we understood that, then it kind of made more sense. But until we'd gone out and had that conversation, it's you don't know exactly what's happening. So I think the thing with care homes is it's all about building the relationships and the trust, and keeping that dialogue going.
Phenomenal. And I think it's for colleagues who have asked the question, will these slides be available? Will the best practice be available? All our webinars are available and they are posted, and you're welcome to look at the links. They're available, and Sarah will post them out again. For those of you who wanted, Sarah, please put them in the chat again for colleagues who are new and don't know about this. Colleagues who've been asking about, will we be sharing best practice? The whole reason we run these webinar series is that the best practice is shared and people are able to get across and ask the questions. I think for those of you who have raised questions about the care homes, like Dr. Abbott has shared, there are no straightforward, simple answers. This is about building relationships. This is about trust. This is about people realizing we're a team, and together we can provide much better outcomes for our residents than we do individually. So please be aware we will be trying our best, as will the clinicians in your local area. But if all the clinicians were doing this together, they'd be in a much stronger place. So, given we are coming to the end of it and we have exactly 4 minutes, one last question that's been posted. What's your advice to people who are in younger years, Lucy, so that frailty isn't just age-related, but people are able to move that much further back from either the clinical or the electronic or any scale that is used?
So, sorry, you're asking about identifying frailty in younger people, or
about how do you postpone the event of frailty?
Oh, I see. Yeah. So
age-related, it doesn't have to be. What would be your advice to colleagues who are here, who are not frail yet, not even in the age have a good chance of avoiding?
Yeah. So yes, I'm afraid it is all about what you do in midlife. So we when we look at aging research, it's all about the life course perspective. So to some extent, even what happens in your childhood will affect how you age. So sort of childhood obesity, etc. Has been shown to then kind of impact on the development of frailty later. So but it really is the the healthy living, healthy aging messages. So maintaining a normal body weight, eating healthily, exercising, as I said, mentioned before, social interaction is really important. Not smoking, moderate, sticking within normal advised alcohol limits. And then if you do develop any, medical issues, obviously being proactive about, keeping on top of your blood pressure, keeping on top of your diabetes, etc. And unfortunately, we do have to take some responsibility for our own health when it comes to those things.
Lucy, as I'm reaching my senior years, I am often worried, will I move socially from being this productive, strong, at least I feel empowered pillar, to one who would be counted as those frequently admitted, using resources for precious NHS, which we don't have. And today, I have to say, you have restored my faith in aging gracefully. Thank you. Thank you so much for doing that.
No
I think
problem.
the ability to be supported early with the need to reduce the need to be admitted, the need for dependence, the need to reduce the resources that are used, but use it in a way where one feels psychologically productive. It is so crucial to the recovery and the hope that all of us cling on to in our senior years. I think the age-old ways of working between secondary and primary care can very easily be shattered if like-minded people come together with the single-minded determination to improve care. Lucy, thank you so much today for sharing a story where we can all reflect to think about what it could mean for our local residents. Thank you to the 300 of you who are logged on today, because without your active participation and your registration, these webinar series would not hold the same value as they do with you all so actively participating and asking questions. Many of you on so many different platforms that in my age, I would fail to recognize them all, but I'm so pleased you're there with us today. Please do take a moment to fill out the feedback form that Sarah has posted. You can scan it. It's called, for those of you who are not as savvy on the IT technology like I am, please use the QR codes so that life is easy for you. But do fill in and share your feedback so that we can continue to improve this space on an ongoing basis and create the safe space we need to keep learning. Next month, with us will be another fabulous speaker, Dr. Neil Mother from Cambridgeshire, who is the chair of the Greater Peterborough Network of GP Federations and the co-chair of Cambridge and Peterborough ICS North Place Bowl. He has been doing some amazing things using the fuller stocktake to create population health workforce initiatives. Now, we have heard how population health work results for improved care. Today from Lucy, we've heard how changing the frailty pathway can make a massive difference, but we will now be hearing the workforce innovation that's taking place, redesigning the whole pathway. There is no webinar that can be complete without thanking the two amazing people, Sarah and Ola, who in the background make this come across so beautifully and polished. I promise you I'd be quivering in my shoes without their support. So a big thank you to them, and look forward to seeing you all next month. Thank you again for your participation. Have a great evening.